So that concludes the major diagnostic features. Now I'm going to move on to the supporting or minor diagnostic features. These are a number of different things. Some are very specific to charge, but difficult to evaluate consistently. Some may be very common in charge, may be very important medically, but they're also very common in other syndromes. So they don't help distinguish between charge and the overlapping syndromes. And some are less common in charge, so they're helpful when they're there, but they're less likely to be there. Or they may not be present in the newborn period, so they don't help make a diagnosis early on. But these supporting and other features might be incredibly important for medical management, and some of the things you're going to hear about later in this course are these other features that are very important for the children that have them. They're just not particularly helpful in telling us, is it charge or something else? So what are these supporting features? Congenital heart defect is a big one. 70 to 80% of children with charge have congenital heart defects. Many of these are very complex, often life-threatening heart defects. And the heart defects really overlap a lot with the syndromes that are similar to charge. So extremely important medically, not incredibly helpful distinguishing is it charge or some other syndrome. Tracheal or esophageal anomalies happen in 20 to 30% of kids with charge. About 20% have cleft lip. 30 to 40% have some kind of a kidney problem. And that can be anything from extra fluid in the kidneys that doesn't drain out properly, to cystic kidneys, to a missing kidney. So any kind of kidney problem can show up. Hypogonadism or genital anomalies is a big thing in charge. You're going to hear a lot more about that later on. Brain changes, brain differences that you can see on MRI. There are actually some very specific differences in imaging of brain of children with charge, some of which may actually be unique to charge, but not enough kids are always getting that imaging that's moved up to the major feature. But if you go back to the December 2017 edition of the American Journal of Medical Genetics, there is one article very specifically on cranial imaging in charge, and they talk about what things are very specific to charge that you could look for. Growth retardation, including growth hormone deficiency, is not going to show up in the newborn period, but is perhaps a significant feature. Behavioral characteristics, particularly obsessive compulsive disorder and autistic-like behaviors. You're going to hear a lot more about those later as well. There are also typical physical features that if you're a medical geneticist who looks at how things are structured, it may be very obvious to you, but other physicians are less familiar with those things and may not be able to evaluate those as specifically. And these can include typical face, hand, neck, shoulders, and even toes. And I will show you the face. The typical charge face is a very square face with a broad forehead, large round eyes. The nose can have a very prominent bridge, a square nasal root, and a prominent columella. The columella is the tissue that's right between your nostrils, and that can sort of be very prominent, kind of sticking out a bit. A small chin that gets larger with age. And here you see pictures of a number of infants and young children with charge, and I think you can begin to appreciate that they look similar to each other. You can also see the typical charge ears and facial palsy on some of them. And here are some faces of older children and teens. Again, you can probably appreciate the ears and the relatively square face and the sort of kind of blocky nose and that sort of thing. And if we move to teens and adults, you can see these people obviously look like they're other family members, but I think on these pictures you can especially appreciate the very short, slightly webbed neck and very sloping shoulders on some of the people. There actually are changes of the musculature and sometimes the bones that give you the sloping shoulders, but that hasn't been really well defined yet. So when you're looking at these major and supporting features, how do you make a diagnosis of charge? The consensus generally is if you have 3 of the major features and at least 1 supporting feature, that's enough to get you a definite diagnosis. Or if you have 2 major features and 2 or more supporting features. So that's, and every clinician is going to come at this a little bit differently and put a little bit different different things in the supporting features and that kind of thing. But that's basically how we do that. Now, beyond these diagnostic features, there are lots of other things that we see in people with charge. So there are many, many, many other features that have been reported that are consistent with charge. So I'm getting at a couple of things. One is pretty much every organ system can be affected. Another is there's not much of anything you can say, oh, well, if a child has this feature, then it can't be charge. I'd be hard pressed to come up with any of those. But what are some of these other features? Some of it is the dysmorphology. I mentioned the webbed neck and the sloping shoulders. There's also the hockey stick palmar crease. Well, what's that? The hockey stick palmar crease is just, it's the upper crease of the palm that goes across, and then it kind of takes a sharp turn and gets very deep when it goes between the index and middle fingers. And you can see it best when you're bending your hand a little bit. My crease goes up there, but it kind of tails off instead of getting deeper as it goes up there. The hockey stick palmar crease is not unique to charge, but we do see it in a lot of kids with it. Palmar creases are simply fold lines, and so that tells you something about the shape and size of the bones of the hand and how the hand is folding. We also see lots of teeth abnormalities. Limb and skeletal abnormalities are actually very common, but there's no consistent pattern to it. We see extra fingers, missing fingers, even to the extent of a claw hand. There may be extra or missing ribs, fused vertebrae, even missing bones in the arms or legs. There can be craniosynostosis, which is early closing of the sutures of the skull that need to be surgically opened up so the brain has room to grow. So lots of limb and skeletal bony problems, but not in any pattern that's particularly helpful for making a diagnosis. There can be immune problems, low T cells, and in the extreme case, absent thymus, which creates a severe combined immune deficiency, which is lethal unless someone has a thymus transplant. So obviously extremely important if you have it, but it's only an occasional finding in charge. But it's something that needs to be thought about and looked for in a newborn with charge. Hypotonia means low muscle tone. So sort of low muscle tone and loose joints. And when you add that to the balance problems, that sort of complicates some of the slow motor development in kids with charge. And seizures, up to 40% of kids with charge develop seizures at some point, and that can be anywhere from newborn to adulthood. So those are some of the other features that have been reported in charge. That is not a comprehensive list. There are lots more. Now, beyond these kind of medical structural features, there are other management issues. And you'll hear a lot about several of these later on in the course, but these are some of them. There are a lot of respiratory and anesthesia issues. There are gut issues with cyclic vomiting, abdominal migraines, constipation. We're not sure if those are related to nerve or what. Difficulty potty training, is that a nerve problem or is that a behavioral problem? Is it both? We're not sure. Sleep disturbances of many kinds. Many people with vision loss have abnormal circadian cycles. A lot of people with charge syndrome have sleep apnea, and that could be obstructive because of large tongue or tonsils and adenoids, or it can be central, that the brain isn't giving the message to breathe all the time. Sensory integration, you have all these sensory losses. How do you experience the world? You'll hear a lot more about that and behavior later on in the course. But those are all major issues for families dealing with these children that are trying to figure out how to give them the best life and the best education and everything else. I think you've kind of gotten the point that charge is variable. It's extremely variable. Every single feature that I've mentioned can be absent in some child with charge and severe in another one. So there's the whole range for every feature. At this point in time, we haven't been able to identify any one feature that is seen in every single person with charge. CHD7 testing is really helpful in less clear cases. We do recommend it be done in everybody that has possible charge. Even if the clinical diagnosis has no question, we still recommend the testing. It's really useful to do. A lot of times people hear the terms charge-like or atypical charge or maybe even charge association for someone who isn't really obviously charged but kind of fits in the category. I like those terms. I think they're very useful. I think even if they're getting there through some other gene, that the management issues are really overlapping. And if using charge as part of their description gets you to where you can get the expertise of all the people that have learned about charge, then go ahead and use it. It's great. So even if it turns out to be caused by a different gene, what we learned about managing charge will still be helpful to these people. And so it's great to call them charge-like or something like that.